people in the medical community. And I recently stepped back from that. Senator Sarah Bryan is now the chair. I've become the Senate Majority Leader, but I'm still very much engaged on issues regarding healthcare, particularly primary care reform.
And you were our guest in, I think it was September, right? Or was it October?
Between the pandemic and having 2 kids under the age of 4, time has no meaning to me anymore. So I don't know. It was a few months ago.
Yeah. So after we have you over, we had some other people from the state Senate. And then it just made sense for us to come back to you because they told us that Bryan is in charge. So then we're back to you. So what I'm going to do is we have a couple of our weekly updates for the COVID-related stuff nationwide and the Delaware numbers. And then we have the vaccine update. And after that, we have 4 agenda items, and we'll just go through those together.
Okay.
So I'm going to start sharing my screen. All right. So this is as of now. I just opened this actually. So the 2 days ago, the total number of new cases at 61,000 and almost 1,600 people lost their lives. And yesterday it was 62,773, about another 1,531 lost their lives. And as of today now, we are at 6,000, but this number is real time and it's early on, so that's gonna probably just increase. But what I see in the last 2 days with the 62,000 and 61, it's going to be pretty similar to those. Although we call these numbers now low numbers compared to where we were in January. If you remember April, May timeframe, these were we were not reaching these numbers. They are still extremely high numbers. Right. Now in Delaware, somehow we were able to do a really good job managing hospitalizations, total confirmed cases. Overall, I think the numbers are good. So with the current hospitalization, we are down to, as of yesterday, we are at 90. So this number was a couple hundred in the last couple months. So now steadily it's coming down. Now, of course, the season, the flu season, winter season didn't help for January, February timeframe, but now we are leveling there. And then persons testing positive, we are down to 15.7. And this number was almost at 27% in January. And then percent of tests that are positive, so that actually is down to 3.9. This is similar to where we were in June, actually. That's really good from that point. New positive cases, we are at 204. This is the 7-day running average. Now, those numbers are, I still want to make sure that I put the emphasis, I emphasize this, it's still high. Like when you look at 200, because when we were really high in the beginning, we were not getting to that number. So I'm still nervous with the total number. But I think with the vaccination being in place, we are going to be okay in the next couple months. So just to kind of follow our agenda items. So from United Medical standpoint, Bryan, when we had the meeting with Valerie, she told me that, well, although she lives very close by, so she knew what United Medical does. I'm like, okay, so we won't take that personally, but we are one of the 4 ACOs in Delaware with almost about 116,000 patients. And then she was so happy to know more about United Medical. So now we are putting more information out there, but medical billing, business development, care coordination, human resources, IT support, and economic care and shared saving agreements. These are what we do for either the practices are owned by us or we are providing the services for our clients. With the 96.7% client satisfaction ratio, this is coming every quarter. We do this for our clients. We share this with our patients and the clients as well. This is, from the United Medical side, I always say the same thing maybe, but I probably will repeat myself. Even though I wasn't born here, I was 25 when I got here. The last 22 years, my home is Delaware, and we are unique patient in the last 12 months is about 116,000, with total number of 430,000, close to 430,000 appointments. This is at the primary care level only. And because we were the early adopter of telemedicine when the pandemic hit, we were able to keep the service up for our patients, and therefore our numbers did not go down. We already covered the first agenda item in terms of the COVID numbers, and our kind of like the routine now is Tanner gives us the vaccine updates, and then we'll continue with our discussion after that.
Okay.
Sure. Thank you very much, Kemal. I appreciate it. So this is something I've liked to share over the past few sessions, just to make sure everyone is aware. We hear oftentimes, I know I've mentioned it previously, that although we speak about the few vaccines that we're very familiar with, whether it be the Pfizer, Moderna, or the Johnson & Johnson now vaccine, as those are the 4 that are approved, there's definitely a gamut of other vaccines out there that are being researched and developed. So this isn't any, it's something that's being closely watched, closely worked on around the world, not just here in the United States. So it's interesting to kind of see the progression of the different vaccine candidates around the world as well. So we've had it since our last session. We had a few move into phase 1 and 2 again. And then with that last session, we were meeting right after the Johnson & Johnson was actually approved for emergency use by the FDA. So that one did get moved up here into the one of those 6 that are approved for full use right now. So we'll continue to kind of keep an eye on this and see how we're getting progression with our other vaccine candidates. So again, as I mentioned, we have a handful that are approved, that being the Pfizer, Moderna, and Johnson & Johnson. All 3 are now being in use here in the United States and are being administered. So we like to keep track of kind of comparing and contrasting the differences that we see between not only the efficacy rates, but also the side effect profile, and any other major logistical differences we might see. The biggest one being that, as we know now, the Pfizer and Moderna are the 2-shot vaccines, while the Johnson & Johnson is a 1-shot vaccine, which we hope will help ease some of the logistical burden with the administration, distribution of the vaccine, things of that nature. So all in all, though, when it comes to efficacy, we see pretty similar rates here in effectiveness between the Pfizer and the Moderna 2-shot vaccines, with the Johnson & Johnson vaccine being that 1-shot 85% effective in preventing severe disease and 72% in just symptomatic COVID cases here in the United States. Now, that's all coming from those clinical 3 trial data. So that's still encouraging news, although we see that little bit of drop in effective or efficacy rate there with the Johnson & Johnson. I'd like to remind everyone that that is still highly effective. That's going to be a great tool in combating the pandemic and helping prevent the spread of the disease. So all in all, again, with the side effects, pretty similar. So with that new vaccine, we hope to start to see some of the numbers increasing here with the actual doses administered. Having a 3rd vaccine in the toolkit to fight the pandemic is going to be big, especially, again, as it is a 1-dose vaccine. We can start to see that get out and get into more arms, hopefully quicker. There's been other news recently with the new administration purchasing more vaccines, and now we do have enough to vaccinate everyone. Where it's just a matter of making sure we can get it properly distributed, properly allocated. So kind of taking a look at where we stand right now. As is, there's been about 131 million total vaccines that have been distributed, with about just under 100 million being administered. Now, that might be just 1 shot, as you can see here, at least 1 dose. We have about 20% of the population as is, so fully vaccinated is going to be 10%. So with that 1 shot of the Johnson & Johnson, that's going to kind of play into how quickly we can get some of those numbers up. And we're interested to see how that plays out going forward, especially in the next few months. That'll be really interesting to keep an eye on, as we are starting to see the new daily amount of vaccines that are administered reach that threshold of 2 million per day again. We saw a little bit of a dip when we were having some pretty severe weather around the country. So that was definitely causing some hurdles and some barriers to getting vaccine out and distributed. Now that we're kind of rebounding, we're back over that 2 million mark, which, if you remember, is something that we had discussed. If we want to get to a 70% level herd immunity, at least by the end of the summertime, a lot of the data coming out of the CDC was showing that to get to that rate, we want to be at about that 2 million vaccines administered per day mark. So that's very promising news. We'll keep an eye on that as well. Now, this was something I thought was interesting as well. A lot of the data we hear and a lot of the efficacy rates and all of the information we're getting from these vaccines was coming from those clinical trials, those phase 3 clinical trials that were showing that the vaccines were roughly about 94% effective in preventing the spread of symptomatic COVID cases. So what we're seeing right now in some places around the world, particularly in this case, we're looking at some data coming out of Israel as they are starting to reach, I believe they are over 50% of their adult population vaccinated at this point. So we're starting to get some good idea on how effective or how these numbers are playing out since the vaccine has started to actually be administered. So what we're seeing over there is that the data is pretty much supporting that the same numbers that we were seeing with the trials, we're seeing that be reflected here as the vaccine is actually on a mass scale being distributed. So that's really good news. And the addition here is, instead of it just being, I know early on we were certain that the vaccine was effective in stopping symptomatic cases of COVID. So what's coming out of those now vaccines being administered over in Israel, we're seeing that also is, that 97% mark is holds true to asymptomatic cases, which is really great news in making sure that we're slowing the spread and the transmission of the virus as well. So that'll be something to keep an eye on, but that's very promising.
You know, the only thing with the with some of these comparisons, Tanner, when Israel is a very small country and the dynamics are very different. So what they're able to do there versus at the level, at the scale that we are at here, certain things are not going to be possible, but we are still, we are in the top 3 with the vaccination ratio, I believe. But I mean, these small country comparisons, it always makes me nervous because it may give the wrong idea. Like even what Florida population is more than 22 million. It's double the size of Israel. So, and also state systems, like the way that certain things are happening in our country here, with our freedom of everything that we are able to do versus when the government says X, you have to follow in those other countries, it makes it easier from that point. So, but although that's still a problem, it's still to know that they are able to do it. And that's why at the state level, so like with what I'm expecting from our states, take this on the state level, at the state level, so that we are not expecting at the federal government level. So, and I think it makes a lot of sense for us to have our state representatives with us in these calls and share some of these issues and what we think is happening versus what may be happening. So a lot of things can be improved for sure.
I agree. Well, I just wanted to quickly mention, I'm sorry, the big takeaway there was, I agree on the differences there in the actual administration of the vaccine is going to be different. But what we really wanted to highlight was the size of the amount of people that they have vaccinated is clearly more than at least the clinical data. So it's just reflecting that the transmission or the effectiveness in reducing the asymptomatic transmission of 97% is holding true. So while there might be differences and different variables playing there in the administration of the vaccine, completely agree on that. But just wanted to note that we're seeing the effectiveness at slowing asymptomatic cases is holding true to the data. So
that's a really important point. Now, the updates that you have given us, they were needed, and that's really good. Now, one thing that actually I need you to say for this one as well.
Sure.
One of the issue maybe, because we haven't dealt with something like this, and I was going to ask Bryan later on, but maybe we can have that discussion now. Just to give you a real life example yesterday. So I get messages from our physicians, and they're saying that, look, we don't have enough people left on the 1A and 1B, and then we have vaccines coming in, and then can we go to the 1C? Now, our immediate response was, no, you can't do anything because the state tells us you have to follow. It's almost like if we were doing that, if you are committing some crime versus, well, we are trying to, the goal is to get everyone vaccinated. So there are certain rules, I think maybe they are set too strict that actually doesn't allow us to reach out to more people. Now, Bryan, I think, I wish that I talked to you earlier, probably in December, January timeframe, but it just didn't work out. The vaccine rollout was a huge problem, and it's still a problem. So the primary care offices were not utilized properly. You were in some of those town hall meetings, but I know that you work with the governor directly. Now, this example from yesterday, I'm hearing what physician wants to do, and then when I get the message, and when sometimes we are playing the devil's advocate and then say, look, if the state says this, just follow that. Versus, well, we have to be more creative in a way that if it's all about access, that should be available to more people. So since this is kind of like the transition item, so do you think we handled the vaccine rollout well? And if not, what can we do to improve?
Well, there's no doubt that it's not a perfect process, and there's no doubt there were specific examples where you're frustrated and you think, is this really have we really done the best we could? Or I just think it's a combination of challenges, from the infrastructure required to store and efficiently deliver vaccines that require the cold storage. I mean, that creates a different situation than if you had Johnson & Johnson from the get-go and able to distribute it to primary care offices in a different way. So that's a big part of it. And more broadly, I would say that there definitely were some communication issues. There continue to be ongoing registration technology issues. And then you also have the issue of, if you want to try to get, shots in the arms ASAP, that's different than whose arms are the most important ones to get the shots into. And even then you have the issue of, okay, well, certain people are more susceptible to negative medical outcomes or health outcomes. But, if they are individuals who maybe are able to isolate more reliably than others who have to be out there for their work or their jobs or economic activity, you add all that together, and it's basically an impossible situation to have it go perfectly. It's definitely an impossible situation for everyone to be happy. I mean, I've seen some extremely heated feedback from constituents who are extremely mad at they haven't had the vaccine yet, and they are blasting away at the governor or the government more broadly. And then the next day they get the phone call that their name's, it's their turn for the vaccine, and then a few days later they have their vaccination. You see them praising the governor and praising the government. So it's an imperfect situation, and amidst all of that, even for those of us who've been able to stay safe, you still have tragedies unfolding every single day.
Well, I may be one of those people too. I did criticize John Carney very kind of openly in the beginning, but I'm sorry interrupting you. But my problem with the way that we are handling this is like how the entire workforce and the access that we have from the primary care offices, how we left them out. So, and we have people who can actually do the vaccination better than the hospital systems. Definitely better than the DMV. I don't know if you watched the session that I did with Valerie or David, but when I went to get my address change or my driver's license, I found out that day was the first DMV day, and it was closed. So then I'm waiting for, there are 300 cars on just waiting, older people, elderlies, and then I was shocked that it was closed. Because I was a little bit late to change my address. It's only 1 year it took. But then I go there and it's closed. I'm like, why are they closed? And then, vaccine. I'm like, who's doing the vaccine there? I could have given people like MAs, medical assistants, providers for those activities too. I'm like, why are we not utilizing those resources more efficiently? So it's always coming back to like when I talk about these and why we do these sessions. We started with different state officials, you were one of those in the beginning, and different technical people as well. The issue all comes down to, from my point, is the patient and primary care advocacy. So can we actually have a better and bigger and louder voice for our providers and for us? And this is again coming down to that's why I was saying that I was asking this question early. But if you look at this new study, Tanner prepared this for me. The people would actually follow their doctors or healthcare providers more than they follow CDC. If they know that their vaccine, if they're going to get the vaccine and then their primary care or their provider got the vaccine, they would trust to get the vaccine at 79%. And then if it's given by CDC, it's 60%. And family or friends is 58%, state or local public, don't take this personally, is 57%. Pharmacists at 54%, and religious leaders at 17%. Now, honestly, I did not know about this study until like 20 minutes ago. Tanner can tell us how many total people was included in this, but when we know that they trust their doctors the most, and when we leave those guys out of the decision-making process, and unfortunately what we decide on these meetings, it just makes it so difficult to do our job, but also we are not able to help you, help the state. So that's kind of our goal. We just don't want to do this because it helps us. That's not the case. It's the whole thing is about we want to be able to help the state that we live in first. Now, we are looking for some changes, and that's why we are reaching out to you guys. What can be done to make this better? Now, I do want to share a couple other things with you, and then we'll come back to this advocacy discussion. I don't know if you want to add anything before we go to the next.
No, just that broadly speaking, I'd say I would love feedback and specifics of what can be done. It seems like Delaware, the numbers overall indicate we're, sometimes we've been closer to the top of the pack, definitely kind of more middle of the pack in some ways now in terms of how the rollout's been going. And I have no doubt we could do things better, could have done things better, could continue to do things better. And the issue is just in the heat of it, how reliably and smoothly can you transition some element of it? I'm not saying that. It's been frustrating to kind of strike the right balance of trying to push for improvements and change, but also understanding that only so much can be done in the moment. And I don't know, for example, how good an overall explanation it is to talk about the somewhat unique nature of the cold storage delivery in terms of being able to then rely on a much larger number of providers to be able to administer it. So I'm all ears for how to make it work better. Please engage me in detail, offline only for purposes of time today. And I will help push for whatever improvements. And I found DHSS and DPH to be receptive. But I've kind of all along been looking at it, well, even though we can identify one-off improvements, and certainly the issue of equity and disparities based on race has been very troubling. How do we compare to most of the other states, especially ones that are similar to us in a variety of characteristics? And if we're doing okay, relatively speaking, to me, that's been sort of the benchmark. But I would love to talk in more detail with you about what we can do and push for improvements as soon as possible.
No, that's really good to hear. Now, I do want to share one new item with you. This is more kind of like an FYI for now. Maybe we can have a discussion later on. When I did this, I did not include any insurance company names or any employers. I just used the percentages. I don't have dollar amounts, but you'll find this very interesting, actually. Now, one of the biggest problems that we have is actually one of the reasons that we even have an accountable care organization is part of the triple aim is the cost and the quality. Now, the cost reducing is a huge focus. And then when we look at what we have done in the last several years, we are able to reduce the cost to the insurance company. Now, I'm gonna share this with you. So what we see here is we were able to, this is a 2018 to 2020, 2 year, we are able to reduce the cost for the insurance company, for their people, by 20%. Now, earlier I said that I won't mention any employer names except myself. United Medical cost went up by 18% in the last 2 years. Now, this is 20% down, so that means people, the cost of the patients to the insurance company is down by 20%, although what insurance company is charging is up by 18%. So the gap actually is getting bigger and bigger. So while we are trying to reduce the cost, we are not seeing the reflection of those on our premiums that we pay for our employees. So right now, what I had to do for our United Medical employees, I had to increase the portion that we are covering significantly because the cost went up so much in this last several years. What we were paying before, it was like 50%. It became like 25% of the total cost. So then we had to make an adjustment. But when I was doing that adjustment, I said, hold on a minute. So we have an accountable care organization. We have the market data. So the insurance companies, this includes the Medicaid. So, before we provide anything for public, I want to make sure that we kind of go through a verification system. And then I said, okay, maybe private insurance we did okay, but what about the Medicaid? The Medicaid costs also went down. The ones that we are managing, at least from the market. So, well, if they're going down, and I said, well, I did increase our employee, what we cover for our employees, but why did the cost go up? Like the whole point of the, ACOs and seeing the successful results, it is reducing the cost. Why don't we see those reflections? Now, it's not a question for right now, but I would like to discuss, unless you would like to make any comments on this one. This gap now is almost at 40%. We know that medical loss ratio of 85% is there for a reason, so that insurance companies are not making unnecessary profits, or they're not just increasing their profit margins, but there's something that doesn't add up. And because, again, we have the information for us to be in these decision-making committees, to question these better, to give you guys a better feedback and real stories, I think it makes more sense from our point, but I can provide more detail for that later on. One of the other insurance level issues that we have is the unfair, almost like uneven, unequal, unfair way of insurance companies are treating the practices. So in this slide, what you'll see is this part is different insurance companies and their timely filing limits. Like if we take Aetna, for example, provider has to do the first initial filing in 120 days, and then we have 180 days for the appeal. So the total time is about 10 months. On this side, this is set by the state. So it used to be higher. That's why I'm saying actually state was helping in this one. They reduced the 3 years down to 24 months. So they can come back to us and then take the money back from the paid claims up to 24 months from the original payment. And, at some point when you always see these differences and then you're always on the wrong side of this difference, then you're like, why are we having these? So now, one of the things that we wanted to actually talk to you is, can we actually make this standard for everyone so that if we are at the level of 10 months or let's say 12 months, can we not limit that for 12 months? Now, for providers, especially solo or smaller provider offices, they may not even know that money is taken back because they offset the payments from the future claims. And I can tell you many providers don't even know that this is happening.
Mm-hmm.
do you have any suggestions or anything that we can do from your side?
So love to continue to talk in more detail offline and learn about it. My overall reaction is just that I get frustrated anytime any part of this doesn't focus on patient care and patient wellness and sustainability of those who are providing the services to keep people well and to heal people. So it is a very frustrating situation. The short answer to your most recent question here is I don't know exactly what we can do to standardize, but it's quite possible that we can do something to standardize it. So I'm all ears about that. I'd have to learn a bit more about, the pros and cons of, obviously having different insurers have different systems, flexibility sometimes is a good thing, but, predictability is also, and uniformity can also be a good thing. So I need to learn a little bit about that. And to your previous point about the gap, I would want, that was Delaware specific data, the 20% versus 18%. Is that Delaware only?
Delaware only.
Yeah. Delaware just is as a small market with the limited number of insurers overall, certainly one major dominant one, and a limited number of hospitals, one major dominant one. It has data that just looks so different from some other jurisdictions. So figuring out what to do about things is not always the same solution as other jurisdictions being able to rely on. So I would want to dive into that too. Not to mention that Delaware also being a place where so many retirees are coming, it additionally skews some of our healthcare costs and expenditures. So Delaware is a very complex animal and creature to try and work on these issues. I would want to talk to you in more detail about some of the underlying numbers and figure out what we can do.
That would be great. So I'm going to ask Anthony Anugwe, our Director of Contracting, to join us for our last part of the discussion, which is pretty much mainly on the representation of the ACOs and the state committee structures and all the issues that we are discussing today. Actually, the maybe origin of those problems are not being able to be represented properly. And because we have done so much in the last several years to organize our physician offices from the clinical integration to the financial integration, then they are able to do a better job. We are able to better represent them. And we want those reflections, those to reflect on the representations. But now Anthony, I think Anthony is in his home office, so he's with us. Hey, Anthony.
Hi, Kemal. Hi, Senator. Nice to meet you again.
You too.
So what I see, one of the big issues for us is I just took the snapshot of who's on these healthcare committees. And, it's interesting how the insurance companies and hospitals, they have like a set seat default. And then when I provide services for 116,000 patients, that doesn't get us a seat in the main decision-making committees. But like a brand new insurance company, let's say, and I'm not naming any of those for any reason, just example, public knowledge. Like if there's a new Medicaid managed care, like MaryHealth, they get a seat automatically, just because what that position is for these committees. Or the hospitals, they all get their own seats. And then we have the state people. And then, interesting enough, they pick people, providers who are like somehow connected to the either hospitals or others. Many of them have different roles. Someone who can be the trustee of Christiana Hospital can be listed as a solo provider or the private practice. But the person actually is the board of trustees of Christiana Hospital, for example.
Wait,
so
who are you thinking of in particular for that?
So I'll give the name later on.
Okay.
So,
well, I just want to make sure I'm hearing you correctly. Believe me.
Like Dr. James Gill, for example, he's listed as a private practice, but he's on the board of trustees, I believe, of Christiana Hospital. At least his website says that.
Gotcha. Okay. No, I would just say that and Dr. Gill in particular, I'll say there's been no shortage of disagreement between Dr. Gill. He certainly is there as an individual provider perspective, trying to advocate for the addition for significant enhanced investment in primary care. So I hear your point. I'll
give you one other example, so then we are not just being not fair. Like Lolita Lopez from West Side, she's on the board of Christian Hospital.
Okay.
The West Side has a very specific, reason for the population, for the poor population has been out there, but then the CEO of that is the board of at the board of Christian Hospital.
Right. No, I definitely not rejecting your fundamental point. I just would note that the first example in terms of Dr. Gill clearly is there as an individual provider, and there have been many times where, and it's all public meetings, so I'm not speaking out of turn here. This is all in the public meeting, and I've agreed with him so many times in sharing his frustration of the lack of primary care investment and believing that hospitals and insurance companies have not been forthcoming about other alternative solutions to what we're trying to propose. If they've got other solutions, great, let's talk about it. He certainly has not pulled punches. So, but I don't reject your fundamental point or concern, and it's interesting because I don't recall at all. This wasn't like a submit your application, let's look at your resume and let's see, oh, you're on the board of the hospital. There wasn't that process to it. I'm surprised to hear it because I've not seen at all in the 2 years or 3 years of this group any indication that he's pulled any punches. So I kind of smile and laugh about it in that regard. But I think more broadly to your point, what I would say is you see when you form task forces or commissions or collaboratives, membership is a very tricky thing. You want to try to strike the right balance. You have to keep it narrow enough that you don't, having like a 25 or 30 member task force is extremely complicated and complex to try and coordinate schedules and whatnot. But in terms of ACOs or other aspects that you're bringing up here, if there's room for improvement, we should take a look at improving it.
Yeah, so, the changes that we have since 2016 with the Medicare MSSP, United Medical is the homegrown Delaware practice, Delaware ACO. And then we got this nationwide ACO in Delaware, Aladade. So I put us together because we are private. And then on this side is the other two ACOs, either Christiana Hospital owned or the St. Francis with the Medical Society membership partnership. But the nice thing about what we have now is, at least from this point, these two sides, we are able to increase the service almost to 80% from these four organizations. And then since Christiana and St. Francis and Medical Society are getting their voice, they get a seat for their voice, then why don't we add the two ACOs with some standards that we have, that they should have X many patients and they should have contract with Medicaid and Medicare. So it's not like some concierge service ACO that we don't want, of course. But I think having these ACOs and having a formal role, just like the hospital CEO is getting it or the insurance company is getting it. Now, the other thing that I want to make sure we are on the same page, Medical Society, and I have nothing against these organizations. Medical Society does not represent everyone, every private practice, because Medical Society also is in the business of doing business rather than being a society for the providers. So in many cases, for example, my organization is competing with Medical Society, just like the ACOs, for example, they have their own ACOs. And then now, if you're a member of Medical Society, then you want to be on on that ACO versus joining us or joining Aladade. So, and then they sell insurance policies, I believe, for small employers, which some of them may be harmless, but in the big picture, it's not that innocent. So then we are our own medical society for our own ACO. We are the central office. Anthony and other directors that I work with, my leadership team, my providers, my board, they spend countless hours to be where we are today. Now, we cannot make any public comments yet, but we will share this later on with you with our Medicare population. We are, when you see actually the total numbers for the last 4 years, we are the least expensive ACO for Medicare. But then this year is going to be even something very different as finally we are seeing the results. So while we are doing so well, and then, why it becomes important, you're going to say, well, come on, why do you even care about these committees? Because we are in healthcare and it's heavily regulated. So just from the vaccine rollout and the testing in the beginning, we have seen how state actually can impact this decision that state makes, how it's impacting our day-to-day life. Okay. So then it's my obligation to my providers to be representing them in a proper way. And we are in some committees at different, I think 2 of them, I don't know if they are decision-making committees, but just like hospital, insurance company, and medical society, that's what I'm actually really, that's my agenda. So, and then, you know, since we start doing these live sessions, the main thing was how can we actually, what can we achieve with these? So we reach out to our patients. Our employees also benefit from these sessions because part of the communication with the, you know, digital world that we live in, we can't do enough communication unless we do these. But then we say, well, we also we communicate with you guys better, and you are extremely nice, and you were able to you come back to us very quickly, even for the second session, and we really do appreciate your support. But also, we are kind of crying for help to make these more tangible, so that we can see the results of our efforts. And next time when these things are happening, then we are better prepared. So, you know, we can actually, our organization can stay stable for the long term. Otherwise, we'll have issues.
Mm-hmm. Sure. No, I completely understand why you'd want to, you know, be even like formally have a seat on the different groups. I'll say a couple of things. Number one, the groups meetings are always public, and so there are definitely entities that are not formally on the group who are always able to give public comment. Now, I understand that that's not the exact same thing as being on the group. Again, when putting together these kinds of groups, usually through legislation, it's always going to be tricky of like where you draw the line, like who is, you know, who now if there's an insurer, you can almost always guarantee Highmark, for example, is probably going to be on there given the role they play. If there's a hospital, you can almost always guarantee Christiana Care is going to be on there. But I do think in terms of, you know, and I'm thinking through it as you tell me in real time, there was definitely not, as I recall, any kind of conscious rejection of having ACOs formally listed. Certainly United is chief among them. So figuring out moving forward how that best fits in is certainly just, again, the comments today, the questions from you today sticks with me, right? And so figuring out moving forward, whether it's this collaborative, which is getting ready to morph into a bit of a different role, including paring down membership as part of the final legislation that we're going to propose, might not be the group that does it, but other groups in the future, for example, might be where that would come into play. I do want to know a couple things real quick, though. Dr. Jim Gill, you mentioned before, he's not, that's my knowledge, he's not a member of the board for Christiana. I think what you might have been referring to was he had formerly been employed. I don't think he still is, but it's certainly affiliated with Christiana as a researcher and perhaps as a medical provider before.
It's on his website, but I can double check.
Okay. Yeah. No. If you go to the Christiana Care website, he's not listed as a member of the board, which again certainly lines up with the fact that he's been very, very, you know, fierce in his advocacy of primary care providers individually in a way that often has been, you know, not in full agreement, at least in terms of timetable and methodology for how to try to enhance primary care investment. But fundamentally, I completely hear your point with regard to membership on these groups. We'll figure out any existing groups or new groups moving forward, how to best strike the right balance. Number two, you can always participate via public comment. And number three, as you've done today, albeit in a live format, which is fine with me personally, don't be shy at all about reaching out to legislators or others and saying, wait a second, guys, you know, here's how we feel about this. That is certainly the you know, a fine way too to make your points and make sure your voice is heard.
Well, we do appreciate that. And I know we are going to follow up with these items with you, and then that's what you were offering even before these sessions. And I just want to make sure that we have some base and we discussed what our expectation is, and then we'll see. We'll look forward for your help, and also we want to be helpful. We want our workforce to be utilized properly. We want, like, I actually manage and okay, the only state-wide cardiology group is my group. So this includes Sussex. Now, I'm not saying this in any way other than Sussex is not an easy place to hire people. Mm-hmm. And I have statewide cardiology network with Delaware Cardiovascular. So the biggest surgical group, the only group in Kent County on pulmonary and sleep. Like it's not just the primary care, obviously. So when you look at it from the podiatry, for example, with 12 different podiatrists, actually 14 now, Brandywine Podiatry, they are statewide. So in order to keep this, because we want the quality and reducing the cost for not only for people who are not on Medicaid, but for also Medicaid population, the only way that can happen is the private practices are in business. And I'm the reason for these practices to still stay alive, but I can do only so much. So, and that's why we are reaching out, and I know that you are going to help us. So
you've not been shy today, and I appreciate it. I mean, I think it's important to bear in mind. So part of it for me is going back in time and trying to reconstruct what the thought process was, just to better understand kind of, where that came from. But certainly moving forward, it's not a matter of going back and only reconstructing. It's also moving forward. It's remembering kind of what your points here and figuring out how that fits in. Just by way of quick example, I'm personally not looking to form a new group, in anytime in the near future to address these issues. We're hoping that we're about ready to introduce legislation that will address these issues. But to your point, earlier slides, there are ongoing issues in healthcare that don't relate specifically to primary care reform. And so if we form a new group to tackle those, then your words from today will be echoing in my head, believe me. So much appreciated.
Well, thank you so much for joining us. And we'll be back next Friday, same time. Actually, I'll be in Turkey, so this new world is so interesting. So although I'll be in our Turkey office, I'll still be doing these live events. So it doesn't matter where we are anymore. So the physical office doesn't mean much. So we are trying to, maximize our benefits from the pandemic that we are going through. But thank you for joining us again.
Safe travel.